was hoping to zoom in a little, but the test looked fine.
You look fine. Mm-mm.
Can you hear me, or should I get headphones too? Okay. Okay. And it's not echoey. Is that a little better?
All right, everyone. How are we all doing today? And I'm here. I'm joined by the lovely Erin Elliott, and you guys should be seeing a split screen at this point. And we're going to be talking today about what our title talked about, the 4 steps to implementing sleep in your dental practice. And I think we should be more specific. We are referring to obstructive sleep apnea therapy in your practice. So be sure to take a moment to share this to any of the different Facebook groups that you're a member of, or to send us a comment below. Hopefully being able to see all the various comments that come through on here. So Erin, how's it going?
It's going well. I don't know if we can see us. The first slide is still up. There.
The live feed is going to be a few 20 seconds behind based on the way I'm sending it out.
Yep, no problem. I am doing great. It is summer in Coeur d'Alene, so I am about to go to dinner on the lake, and I'm the ultimate multitasker. I wanted to be here with you.
Well, I want to know what you're doing in your car and why your husband's there with you.
We're going to be meeting my good friend and associate, Dr. Kelly Harness, and her husband.
Can we say hi to Tom real quick?
He's right outside talking to someone we know.
Oh, okay.
I wanted it to be steady, so that's why I'm in the car, because I can plug it up against the window.
Well, Erin, why do you want to do this webinar?
Well, I just think there's a lot of misnomers and confusion and noise. And I do get a lot of, I get questions every day of like, okay, what codes do I use? I'm like, well, what does the sleep study say? Oh, they didn't have one. So I just think that we could just make things simple, as you are so good at, and just answer some questions and maybe some confusion, like I said.
All right, so why don't we go ahead and get started? There's no reason to goof around here. Lewis Meyer says hello, Hutan says hello, Kevin says hello, Matthew Standridge, the ketodontist. You know what's really weird is my team members one day were talking to me if I knew this dentist that does keto, and I was like, yeah, I should talk about Matthew. I know him very well, so it's always fun. So, but it's interesting.
Yeah. Are you?
So I'm going to go ahead and share a screen here, and now you can see what we're showing you here is, really what we came up with is a 4-step process or workflow to helping your practice implement sleep apnea. And what I've found over the years is that too often dentists are focused on the last step, which is treatment. And the truth is, before you can get to the treatment phase, you have to get through the other 3 phases first. And quite frankly, those 3 phases, the awareness, the diagnosis, and the financials, are where practices are getting stuck. It's not that we don't know how to treat or how to make an appliance. Quite frankly, it's the easier part of what we do. It's all the things that it takes to get there. So without a commercial, I would not be, this webinar is brought to you by 3D Dentist, of which Erin and I are part of, along with Hutan, Sully, JP, and our good buddy Davel, who is a master at CEREC dentistry. But Erin, where I'd like you to start, if you don't mind, and I'm just going to be kind of the talent. I'm going to be the talent today. You can be the real talent. I'm just the moderator today. Where I really want to start is kind of, what is obstructive sleep apnea?
Well, it's exactly as it says. When we're upright and awake during the day, our muscles it's easy to be active and keep your airway open. At night, when we're horizontal and relaxed, the airway can collapse. The collapsing usually is in the tongue and soft palate area. And the biggest takeaway I think you could have is that you could be skinny and petite and young and still have obstructive sleep apnea. Too many people, especially physicians, think it's an old fat man's disease. So there's a lot of people under the radar that aren't getting good quality sleep, that are struggling, but don't know what the answer is. So they go and get their thyroid checked and their hormones checked and get sleeping pills because they're not sleeping through the night. And unfortunately, untreated obstructive sleep apnea can lead to many different diseases. And most patients, if you look at this graphic here, don't realize how large the tongue is, but we as dentists do, meaning that we stare at airways all day long, we fight their tongue, and there's a lot of dental signs and symptoms we can look for clues that someone might be struggling with this.
Okay, so the next question I'm going to have is, then we're going to start focusing on is, how do you measure, and are all sleep apneics the same?
Well, there's 2 major types of sleep apnea, not to get too technical. One called central, and then the other is obstructive. But essentially, what a sleep test does, it's going to measure your airflow. In order to be an apneic event, your airflow needs to cease for at least 10 seconds, and your oxygen has to desaturate 3 or 4%, based on whether you're private insurance or Medicare insurance. And that gives us a number. So essentially, the sleep physician, sleep tech, sleep test quantifies how many times you stopped breathing completely or partially for 10 seconds or more with a 3 or 4% DSAT, and adds and divides it by the number of hours slept to give us an AHI, or apnea hypopnea index, as you see here. So there's mild, moderate, and severe sleep apnea.
Okay. And then the last thing in terms of the why that's important, I think I'd like to touch on this if you don't mind. And that is why is sleep apnea even important, to be quite honest with you. And the truth is we have to look at it really from a broader perspective. And sleep, why is sleep important, and what does sleep apnea do to affect sleep? And really what sleep apnea is it's constant or intermittent disturbances of your sleep. In other words, it's disrupting your sleep. And the reason that's important is your body goes through multiple stages of sleep, and during each of these stages of sleep, various bodily processes are happening that are super important to your overall regeneration and your overall health. And when we have sleep disturbances, whether it's for a second, whether it's for 10 seconds, whether it's just stopping breathing or just having a decrease in oxygen, you disrupt this sleep. And when you disrupt the sleep, these processes don't happen, and you, to a certain degree, start this sleep cycle all over again. So if we go back a slide here, and we'll take someone like myself. I'm a severe obstructive sleep apneic with an AHI greater than 30 when I'm unmanaged. So that means every 30 times per hour, every other minute, 30 times per hour, every other minute, I am having a sleep disturbance. And what those sleep disturbances are interrupting my sleep at some point in this cycle, and that's really the problem for us. So,
and not just interrupting the deep sleep, but the way that our body kickstarts the breathing again, it like panics because oxygen is the number one drug our body needs, and it shoots out adrenaline or cortisol to kickstart our breathing, and that has a ton of effects, inflammation, all of those things too. So it's no wonder that it's such a bad cycle to be in.
Yeah. So now that we have a good understanding of why it's important, and I think that's that's a super important step to get your team on board to get that conversation started so that you can have that conversation with patients. I think the next step we should kind of go into awareness, Erin, is the first step of our sleep workflow, and that is awareness. So, Erin, why don't you go ahead and give us a brief talk on what awareness is?
Well, awareness is kind of twofold. And so as dentists, we are in the perfect position to create awareness. We know our patients, they see us twice a year. And if the whole team is trained, then we're all talking about it. But the first thing that we can do for awareness is that we have our patients' health history right at our fingertips. So all of the health consequences that sleep apnea can cause, if our patient has them, we can maybe ask them how they're sleeping. For example, diabetes, hypertension, acid reflux. Those are kind of the easy top three. And we have even changed our health history questions to help screen and reflect some of that. And then secondly, there's dental signs and symptoms that we can look for. It's an anatomic issue, not just, like I said, an age and a weight issue.
Right. So basically what I'm hearing you say, Erin, is that there are sorry, I'm trying to be the producer and everything all at once.
You're doing good.
So what you're saying is that we're creating awareness by looking at two specific areas. What I kind of tell people is we're looking at physical conditions and non-physical conditions. And the physical conditions are those things as dentists that we're trained to see: enlarged enlarged tongues, scalloped tongues, elongated uvula, high vaulted palates, large tori, things that can kind of shrink the airway to a certain degree.
And I'd say that the top three on those is bruxing, acid erosion, bruxing or clenching, acid erosion, and the scalloped tongue. Scalloped tongue is a big thing.
And the important point on scalloped tongue is scalloped tongue doesn't always look scalloped when you have your patient stick their tongue out, does it?
Right. You have to catch it as soon as they open.
Yeah. So those are the physical things that we look at. And then the non-physical things, those would be the medical conditions that are not necessarily caused or caused by, but are associated with obstructive sleep apnea. And, really I'd like to add a fourth one, Erin, but there's four main ones that we teach our team members and everybody else to look for. Number one is cardiovascular issues, high blood pressure. Number two is diabetes. Number three is going to be acid reflux. And near and dear to my own heart is psychiatric issues, depression would be.
I'm glad you didn't say the other one I thought you were thinking of.
So what we're seeing more and more, and as a dentist who has a wife who's a psychiatrist, we're seeing more and more that patients who are under treatment for depression are having more and more sleep issues. And so those are the four main things that we look at from a non-physical side of things. So again, a quick commercial, because what would we be doing without a commercial? One of the things that we do unbelievably well is that we provide outstanding training that is focused on implementing sleep apnea in your practice, focused on getting your team on board, focused on making sleep apnea a team-driven process. Erin and I, and Erin on her own often does wonderful seminars that are focused on providing sleep apnea therapy in your practice. Our next upcoming seminar is going to be in San Diego on September the 20th and 21st. And then we have a program in Raleigh, November 7th and 8th. So we would always encourage you to join.
I think it's important to point out here too, is even though that we are 3D dentists, you don't have to own cone beam or anything like that. That's the course that I teach is not focused on that. We'll teach you how to utilize it, but it's not focused on that. And then the second is that we are both practicing general dentists. This is not my full-time job. It's just sleep. It's just sleep. So, and I'm in Idaho. So like I said, if I can do it, anyone can do it.
Okay. So, and I think that's a critical thing to kind of let people know is that, look, this is what we do day in and day out. We leverage our team members. We help uplift our team members, help them see a path forward for their own career, and we help them see how much we can help our patients. I know Erin couldn't do it without Bree. I know that I couldn't do it without Liz. And I know both Bree and Liz couldn't do it without the hygienist and the rest of the team, the front office team, the assisting team, really kind of pitching in and helping us identify patients. So step one is creating awareness. And what I'd like to do now is move into step two, Erin, and that's talking about the diagnosis portion of our workflow.
Yes. So step number one is that dentists cannot diagnose. And the other part of that is that we should not be making snore guards. What I mean by that is when a patient comes in and says, oh, I just snore. Even physicians have told me that. I just snore. I don't have sleep apnea. You never know what you're dealing with, and you can't tell just by looking at someone what goes on at night. And so the first step is to know what we're dealing with and getting a diagnosis from someone other than us. So helping them get to a sleep test is the next step so we know what we're dealing with.
Now, Erin, are dentists allowed, while dentists cannot diagnose, are we able to assist our patients in getting a diagnosis?
Yes, we are. And so essentially there's a few different ways to get that patient to the sleep study, and that is to refer to the sleep lab and the sleep physician that they may have a home sleep test. You can do a third party where you order the sleep test and it's mailed to the patient, or you own your own units and have a sleep physician review and sign off with a diagnosis. And
I do want to mention that in many states, in most states actually, dentists can dispense home sleep tests. Do check with your state board and your local state laws to see where your state stands on this. And if your state if you have any questions, please don't hesitate to reach out to us. But typically what happens is all diagnosis is done by a sleep physician, and then what we do when we dispense an HST is we're essentially assisting the patient to get that official diagnosis from the sleep physician, and then at that point the sleep physician makes a determination of whether or not oral appliance therapy is first-line defense or CPAP is first-line defense for our patients. So getting the diagnosis, quite frankly, is a hiccup for many people. But the real truth is just need to make it easier for your patients to get it. and help participate in that when possible.
T-Bone, the last thing I need to say about the sleep test is that's where you turn awareness into urgency. It is my favorite part of our course, and it's my favorite part with a patient when I sit down and review the results, and all of a sudden they're like, I was just here because my wife kept nagging me, or Dr. Elliott kept nagging me. And now it's like, when can I get this done? Like, I want it yesterday. I was like, you've probably had this for 15 years, and all of a sudden now I did my job too well. But it's once you sit down and show them what's going on when they're asleep and unaware, the light bulb goes off. It's magical. That sounds dorky, but it is.
Oh, well, you are a little dorky, just so you know.
Yep.
All right, and my wife's going to tell me I was dorky for that comment. So, all right. So now, and I'll cover the financials part of this if you don't mind, Erin. And
yep.
So now we're on to step 3 of our workflow. So again, step 1 is we create awareness, and that is every team member in your practice, from front office with the health history form, from your clinical team members, from when they're talking and looking at your patients and looking in their mouths and seeing physical symptoms, and then looking at the medical history and seeing non-physical symptoms. Once we have that conversation, our suggestion to the patient is to get a test. And this test is to determine whether or not the patient actually has obstructive sleep apnea or central sleep apnea. That diagnosis is done by a sleep physician. So let's pretend in this particular case, and as many times as the situation, our patient has been diagnosed and it is determined, or the patient chooses, that they would like to partake in appliance therapy to help manage, not necessarily treat, but manage their obstructive sleep apnea. So what I always tell people, the number one way is we always have to make this affordable for our patients. And the easiest way to help our patients make this affordable is to leverage medical insurance. Now, I want to call out to a very important statement I have on here. Reimbursement varies from state to state and plan to plan. What I'm showing here is an actual claim from a patient here in our practice here in the state of North Carolina, and this is the level of reimbursement we can typically expect here in North Carolina. This reimbursement will vary from place to place. So we have the opportunity, because it is a medically diagnosed condition and it is accepted as treatment options, we have the ability to leverage medical insurance. Frankly speaking, if you dot your I's, cross your T's, this is one of the easier claims to get paid. But they're going to make you jump through some hoops. That's why we always recommend working, at least in the beginning or even forever, working with a qualified and knowledgeable third-party biller. And I would like to take a moment to mention my good friend Hutan Shahidi with Code, who can help you with this. And we will bring Hutan on at another webinar to talk specifically about medical billing for sleep appliances. But even when you utilize medical insurance, or when your patient doesn't have medical insurance, or if your patient benefits don't kick in because of deductibles and copays, it is very important to not think that this is driven only by medical insurance. We have patients all the time who choose to elect yes to the best care and choose to have appliance therapy regardless of their medical coverage, and sometimes in spite of their medical coverage. So I always believe in having firm financial arrangements, making it easy for your patients to pay, making it transparent, and making it easy for your team members. And we employ the use of a financial menu in our practice that helps our patients choose various ways to make this affordable. Remember, this is not about price, it is about affordability, and that goes across the board, even beyond sleep. So Erin, you got anything to add there?
Yeah, if you do your job of, building up value and what we're providing, then oftentimes it's like, okay, what do I need to do to get this started today? And so we do have a financial menu, like you said, that we tend to be a little bit more lenient with, I would say, for sleep. But I just want to see people get the help. And as altruistic as I am, I wouldn't do this if I was going into the hole with every patient. So it is possible to get paid by medical insurance.
Well, Erin, if you don't mind me putting you on the spot for a second, can you speak to Medicare and sleep appliances? Because I do believe your practice does do a decent amount of work with Medicare.
Yeah, and I think it depends on your demographic and your area. We do have a large retired population, and I think for Medicare as well, it just makes it a no-brainer for physicians to refer. So saying that, I have elected to sign a contract with our government, close your ears, T-Bone, and I became a non-participating provider, which means you can charge above and beyond what Medicare allows. So Medicare will pay 80% up to their allowable. And that there's about 4 different allowables around the country, 1,800 for the Northeast, about 1,050 in the South. I know our area is about 1,300. So saying that, you can charge above and beyond, and supplementals do help as well. But Medicare we kind of submit the claim and get the money in the bank as long as you follow their protocols.
And there's the important part. As with anything with government, good and bad, you have to dot your I's and cross your T's.
It's so black and white. You have to use a certain appliance. You have 2 choices, essentially, and a certain lab. It has to be what's called PDAC approved. And they have to have, there's just rules about the sleep test and all of that. But Medicare patients are more than willing, usually, to go through those hoops.
All right. So, Erin, now that brings us to our 4th step of our workflow, and that is the treatment step. So, again, we start by creating awareness from the front office to the clinical office to patients before you see them to patients once you see them. We help and assist and encourage our patients to get an official diagnosis only done by the sleep physician. We help find our patients a way to make this affordable. And then once we have all of those in place, we have a patient that actually says yes to treatment, and now we're ready to proceed with treatment. So what I would like to do is, before I turn it over to Erin, is say this. Listen, at the end of the day, making a sleep appliance is about taking an upper impression, a lower impression, and taking a treatment bite registration. There are details that go into each step. You can do this without technology. You can do this with technology. You can do it with alginate. You can do it with polyhydrocolloid. You can do it with rubber base. You can do it with polyvinyl. You can do it with digital impression, whether you're on the CEREC side, the 3Shape side, the iTero side, whatever side you're on, this works, okay? So always think about this from a simplistic point of view that at the end of the day, upper impression, lower impression, and treatment bite, and the bite has to be taken in a good position, and there's unbelievable technology now that will tell you what bite to be taken and what treatment position to be putting your patients to. And if people have questions about that, we'd be happy to bring on some experts to discuss that as well. So, Erin, I'm going to turn it over to you. Talk to us about how to take a bite.
Well, there's a million different ways, and all of them are correct. Essentially, we need a starting protrusion. That does not mean that you bring the patient way to their max, and it doesn't mean that you don't protrude them at all, but you also need a certain amount of vertical in order to have room for the appliance material. So there's a good guesstimate that goes into it. Like I said, there's a lot of different ways to end at that. It always ends up at about the same place no matter how you take the bite. And so I don't know what you want me to say more than that, but we
I
can't see the slide, sorry.
So I think basically I think both of our points is oftentimes we overcomplicate taking the bite. Take your bite any which way, but keep some key things in mind. You have to have a certain amount of clearance for the appliance that you're using. You have to have a certain amount of protrusion to help our patients get effective treatment. And a lot of that protrusion is going to be done with the device or the appliance that you select. And it's important to have a device that fits well, that is comfortable for your patient, that allows you to move your patient forwards and backwards so you can help that. It's important to take your bite without having your patient deviate, without putting too much compression and pressure onto the jaw joints. And so those are the basic things you got to do with taking a bite. I just find it funny that people have a tendency to overcomplicate taking the bite on their patients.
I'm like, am I supposed to complicate this more? Yeah, so that's the thing. There's so much confusion and noise, right? So we teach one way, and I'll even say it's a good guesstimate. But then I get a whole bunch of questions like, well, what about this? It all ends up usually about the same place.
And
but
listen,
you're right.
Go ahead.
Yeah, go ahead. I was just going to say, make sure that you are using an adjustable appliance because you'll never nail it on the first time.
You know, and along those lines, there's unbelievable technology through the Matrix Plus these days that you can actually predict with high level of accuracy the protrusive position at which your patient will be most effective at oxygenating their body. Erin, I've got a slide up here that talks about all the different appliances that are out there.
Okay, well, I only have a few more minutes, so I better get started. There's over 100 at this point, I think. But I would say to have 4 in your tool belt. You know, there are some older appliances that are bulkier, and their mechanisms of holding the patient in place can be uncomfortable. So I kind of move towards the milled, so they're strong, not porous, they're hygienic, and I like the fact that there's not a whole lot of bulk, so that we can have more room for the tongue. It does depend on the patient and how many teeth they have, particularly posterior teeth and retentive teeth. But, you know, I kind of use my guide off of, unfortunately, insurance does dictate sometimes what kind of teeth and how many teeth, like what kind of wear pattern. And then finally, I do think the warranty is important as well. So it's not something cheap and flimsy that they go and tell everyone about if they have a bad experience, but if they have a good experience, they also go tell everyone about how their dentist helped change their life. And so lab fee is really not high on my priority. I'm willing to invest in good stuff because it will limit my chairside time if I don't have to, if Bree doesn't have to continually adjust or it fractures and we're sending it back and all of those things. So being digital is also very beneficial.
Absolutely. And our office has made a decision to only provide digital appliances to our patients. Because what I have found from personal experience, having been wearing an appliance myself, or an oral appliance or oral device for nearly over 12 years now, and having probably worn 8 or 9 different ones, is that the milled appliances have a better fit, a better comfort, and we can argue about whether that's true or not, but here's what we can definitely not have to argue about. Milled appliances smell better, they look better after some years of use. They simply don't attract and retain bacteria.
Let's face it, you don't like to maintain things.
Well, listen, facts are facts. I'm no different than every one of our patients, by the way. So, that kind of is our basically our canned part of the webinar today is to really walk through all 4 steps of the process. And it's not anything that we're trying to hide. It's very simple. It's creating awareness, assisting your patients in getting diagnosed, making it affordable for your patients to proceed with therapy, and then providing wonderful therapy that fits your practice style and your economic style to make this stuff work for your practice. So, that's for the most part, outside of having some questions, that's what I got. And of course, I got to do 2 quick commercials before we answer any questions that may be there. And that is, again, Erin and I do some wonderful sleep training. For those of you that want to learn more, bring a team and learn implementation. Quite frankly, we get a lot of people who have been through some of the academic training where they spent multiple weekends learning sleep apnea, but they have missed the most important part, which is getting it into practice. We have an ability to cut through the BS and get down to what really matters, and that's doing great dentistry, helping our patients, but finding a way to make it happen in your practices. And the last thing is I have a wonderful ebook out there. It's called The Dental Practice Pivot. You can find it at dentalpracticepivot.com. And basically, here is my mission in dentistry right now. I want general dentists to have a great time. I want us to do the dentistry we want to do. I want us to earn more money. I want us to take more time off and love what we do. And I've pivoted my practice over the last 5 to 6 years to where 80% of the time I'm doing the dentistry I elect and choose to do. And unfortunately, 20% of the time I still have to kind of do what I don't love to do sometimes. But it's been phenomenal. We've been able to bring in a partner and associate into our practice to allow me to take more time off, to be able to better take care of our patients. And I have a fantastic podcast that kind of goes over all of these things on essentially a weekly basis. It's not always works out to be a weekly basis, but we'd love to see you at one of our training programs. Again, the next one is September 20th to 21st in sunny San Diego, and the one following that will be November 7th and 8th in Raleigh, North Carolina. So if there are any questions, we are happy to answer those. I'm trying to see how I can see the chats here, or if I'm seeing them all on my little software I'm using right here. So we'll give it a minute or so for questions, and if there aren't questions, we will let Erin go to dinner. But until then, we're not going to let her go to dinner.
No, that's fine. Actually, the whole reason I get to go to dinner, I am on a staycation this week, and I not to make your head swell, but over the 3 years that I've been working with you and know you,
you should make my head swell, please.
My practice has changed tremendously, and you talk about loving your career more. Hi, Bones.
No, this is my mom's dog.
Oh,
this was our first dog we got 4
that
years
you
ago.
gave to your mom.
That we gave to my mom because we couldn't take care of it.
Yeah, that's what I was afraid of with your new dog. No, so saying that, it spills out into your personal life, family life, overall quality life. So if you do listen to you, then good things happen. You just have to do them.
Yeah. So your husband Tom says there's no question, Daddy is hungry. So, but Matthew Standridge asked a very common question, and his question: what team, if not all, would be best to bring?
Oh,
and look,
that's a great question.
The business person me wants to tell you to bring everybody, okay? But I don't think that's what you should do in the beginning. Really, what I believe I call it the 4-pack. What you should do is you should bring the dentist, one front office team member, one clinical assistant, and one hygienist. Okay, bring them, get them on board, bring your strongest, the rocks as I call them in my practice, bring them, get them on board, get them back to your office, talking about this, having them work with other team members, and then send the next set of 3 team members, your next front office, your next clinical assistant, your next hygienist. But here's what I will say to all of this. If you skimp out, do not skimp out on sending your hygienist to this program. Almost half of all the sleep appliances that we do in our practice come from our hygiene department. So it is important. Those are the team members that spend the most time with your patients, who are actually looking in their mouth for, it takes them 8 hours to clean teeth. Just kidding. But, they're looking at there. So I find that if your hygienists aren't on board, you're going to have a little bit of trouble there. So Philip Squatrito, I hope I'm saying that right. When you get the insurance breakdown for the patient, when do you get the insurance breakdown for the patient? Before or after the sleep test? Well, quite frankly, the insurance breakdown, the benefit check, as we call it when we teach, doesn't matter whether or not you have a sleep test. That at that point, quite frankly, I like to get that as soon as the patient says they're even interested. For example, when we get a patient that is interested in a consultation, I like to go ahead and get that benefit breakdown before we even know that they actually have sleep apnea. And that's a matter of knowing the deductible, the copay, and a few other pieces of information. And from that, you can calculate roughly what benefits the patient may have in the event that they actually do have obstructive sleep apnea.
And then when you start billing enough, T-Bone, you get familiar with the local insurances and you can better guesstimate. Because We do teach to have your front desk collect medical insurance cards on every patient, whether they look like they have sleep apnea or not, just for other reasons. And you get a better understanding of what kind of coverage those patients will have. So that's just one more hurdle that you would be removing for patients to move forward.
That's fantastic. Philip said I got his pronunciation correct, and that's because I'm typing as I do it. That's because I had my name mispronounced all my life. So, all right, Erin. I don't see. Somehow I think maybe we went. I don't know what happened here. I lost all the messages on here. But if do you see any messages or questions at all?
I don't have another way to look, but I think we answered some good questions.
Okay.
Yeah.
All right. So if you have questions, please don't hesitate to put them here, to DM us. You probably DM Erin a little bit more than me, but sorry, I couldn't help it. I lost my train of thought. Listen, we're here to help.
HMU.
Well, I don't know what that means.
Hit me up. My kids say it.
I have no idea. Slide in there, as Kevin says. So, Erin, thank you so much for taking time out of your evening, and just want to help people. And enjoy your dinner, and tell Tom we said hello and that we love him, and that we're looking forward to our next trip together.
Awesome. Thank you, T-Bone.
Thank you, Erin. Bye, everybody.
Yeah.